Good morning, all. I am Roshan Santosh, and he is Vishal. So,
Mr. Surendra, 25-year-old male residing in Kumar, a daily wage worker belonging to lower middle class according to modified Kutuswamy scale, came to the OPD with 6 complaints of swelling in the left groin for 6 years. History of present illness. The patient was normal 6 years back. After this, he noticed a swelling in the left groin, which was insidious onset, progressive in nature. The swelling was initially small in size, gradually increased in size, and descended down to the scrotum to attain the present size. The swelling increased on straining and cough, and the swelling was manually reduced. There is history of increased transfer, no history of trauma, no history of fever, no history of lagging or dulling pain, no history of chronic cough, no history of vomiting and chronic constipation, no history of urgency or difficulty in urination, no history of weight loss and appetite. Past history, no history of any previous abdominal surgeries, and no history suggestive of hypertension, COPD, diabetes mellitus, and TB. Personal history, patient is not a smoker and an alcoholic, normal bowel and bladder habits, patient consumes sweets diet, normal sleep pattern. Family history, no history of similar complaints in the family. Summary, a 45-year-old gentleman who is a daily wage worker by occupation, a non-smoker, came to the OPD with swelling in the left groin for 6 years, which was aggravated on coughing and straining and was manually reducible, probably a case of left-sided inguinal hernia. Central examination. The patient is conscious while.
So what significance to the age of the patient?
Old age usually bad.
What is old age? So, yeah. So one interpretation you can say is that you assume it is an acquired hernia, it's not a congenital hernia. So, with respect to this age, what significant history did you take for raised intra-abdominal pressure? You said he's a daily wage worker. We assume you are wanting to hint at the fact that there is some increased intra-abdominal pressure. Any other history that you have taken with respect to age 45 years and plus in our general? You talked about no difficulty in urinary complaints and no urgency. These are the two specific complaints that you talked about. Well, what did you exactly ask? So can you tell us some obstructive urinary symptoms? Can you tell us some symptoms that are suggestive of obstruction to the flow of urine?
And there is an obstruction to the flow of urine. What is the complaint patient have? Is it an urgency is a complaint or any clear patient have? Initiation.
Looking of urine.
Post-maturation dripping. What about alteration in stream? Do you have any association with altered stream?
No flow of urine. It's a related to the hesitancy of urination.
What happens on training in prostate trophy? Yes, it will get stuck. So he has to relax in case of prostate hypertrophy. On the contrary, his structure, he has to strain so that his gel increases. This is the difference. Got my point?
You also mentioned the fact that there is no family history of hernia.
No, you use the word there is no similar history. Please don't use the word similar history in the family history. In the present history, you have find out it is a hernia or inguinal scrotal surgery. Mention that in the history, past history. There is no history of inguinal scrotal surgery or anything which is related. Using the word similar history is a different meaning. Okay?
Is there any tangential or genetic cause for development of hernia?
Genetic reason.
Satan causes vaginas.
So you should be aware of the fact that there are genetic associations that are seen in patients with chronic hernia also. Right? So that is why you do the history. Which collagen is good? Collagen 1, collagen 3,
Collagen 1.
So some points I wanted to make about the history and go back to your first slide. You talked about it started as a small spread, increased in size and reached its present size. We don't know how big it was. We don't know how big it is now. So it started as a small till it reached the current size. So neither do we know what the earlier size was, nor do we know what the current size is. To give you an idea, as texture calculation, it was as many centimeters and currently it is around as many centimeters. Give a rough idea of the size of the swelling. What history have you taken to say that patient does not have any complications due to this hernia?
No lagging or aching pain. Yes. Increase in size.
This is the first time he's come to the hospital. Both are important. So what are the emergency situations that can make a patient with chronic hernia visit a hospital?
Obstruction. Obstructions from condition.
So the patient will not know he's obstructed, no? So what will make a patient come to the hospital?
Pain. Pain.
So what you need to say is you need to phrase our answers correctly. You need to say sudden onset of severe pain with irreducibility is what will bring you to the hospital in an emergency situation. With mild pain, we will go to UPT also like he getting pain in the chronic, but in case he has severe pain which is associated with irreducibility. And thereafter you will be inability to pass these spirits also. Right? This history must be specifically mentioned.
You have put no history of trauma. What do you mean by that? Which trauma will cause inguinal hernia? It causes or not trauma? No. Put that in an order. Because you are putting a first line is itself there is trauma. That is
Prioritize. Please to answer this correctly. Prioritize what you're writing. Trauma and fever are coming first, which are very unusual symptoms in chronic hernia. Why did we take history of weight loss and why not history of weight gain? Any association of chronic hernia with weight?
In malignant tumors,
exercise, will it increase the hernia?
Unaccustomed to work.
Unaccustomed to work will precipitate. And when the patient is going for regular exercise or something, it can also show. Okay, that may not be the reason, but that can bring to the notice of the patient.
Then we move to the next slide. Yeah. So which previous abdominal surgeries can cause chronic hernia?
Draining of abdominal abscess.
Sorry.
Draining of abdominal abscess.
Abscess drainage.
Appendicectomy. Appendicectomy.
No, where will be the abscess? It's the subcutaneous. Most of the abscess will be the subcutaneous. Drainage of the subcutaneous abscess, how it produces a nerve injury? Where is which nerve you are interested?
Ilioinguinal.
What is the plane? Which plane it is? Between two muscles, no? What
Between
muscle?
transverse abdominis and internal orbit.
So abscess you are going to go down to that. Can be abdominal, deep abdominal abscess will be there. They're not common.
So when you write this sentence, you must see an answer to that. So what? Right? Abdominal surgery should be the back of your mind when you're writing a sentence here. So what are those surgeries in this area which can lead to weakening of the abdominal musculature? Appendicectomies, right? And previous abdominal hernia surgery is what you're interested in.
Which appendicectomy?
Which appendicectomy? Answer.
You have seen appendicectomy in one institution now. So what they do? What is the incision they are using now? Or what method? Is it muscle splitting or muscle cutting? So what is why they invented for muscle splitting than muscle cutting? Muscle cutting will cut the nerve. Muscle splitting, most of the nerve will not be damaged. So ilioinguinal nerve, is it a motor nerve or sensory nerve?
Motor.
Motor for it supplies what?
So the sensor supplies to scrotum and the motor supply.
I think you are some mic. The problem with the mic, some audio system you need to somewhere it is echoing. But you need to talk loud. That is why we got a T. You may also get a T. We need to talk loudly.
Ilioinguinal is motor with supplies.
No, madam has said that any sentence when you are reading, always read why, what. This question you must ask. When you say that there is no operative surgery, you must ask why. Why you are going to talk about. In the appendix, just because it is said in the book and you cannot say that. Now, last 45, 50 days, years, most of the time they are doing a muscle. As you said, some of the deep abscess drainage or putting a drain itself, some other surgeries can definitely cause. So ilioinguinal nerve is both motor and sensory. Sensory to the motor to the conjoint tendon. So only when it is injured above, it can produce. When it is injured in the below level, nothing will happen. That is very, very rare.
So what is nice about the history that you have taken is that you try to cover all the points that were mentioned in the previous lectures. Right? But what you need to improve on is that you need to be specific about the points that you are touching about. Like you talked about uterine income, but you did not know what to ask and what to ask. Previous surgeries, you don't know why, weight gain, weight loss. So everything, there is a reason for each of these points which you must know. And we move to examination.
General examination. The patient is conscious, oriented, moderately built and nourished. No pallor, no interest, no cyanosis, no clubbing, no generalized infertility, and no pedal edema. Vitals, BP 100/80 mmHg. 16 breaths per minute, pulse 80 beats per minute, and temperature air febrile.
Why do you look for pedal edema? No, why you are looking for a pedal edema? What is anasarca? So ascites, if there is edema, if there is an ascites, that can also one of the reasons. We have inguinal only. Is it due to other reasons that you are going to look for a pedal edema? How do you look for pedal edema?
Median malleolus. Above the median malleolus, you have to place the thumb for
How long? 5 seconds. You do an exercise in the house and see that 5 seconds what you can do. Okay?
So, testing for pedal edema is a clinical test, right? All the OSCE also now. So, when you are asked about how to test for pedal edema, you need to know how exactly to do it. And what are the parameters that you will assess? One aspect of it you mentioned, that you will press on the medial malleolus. For how long and what you will look for is what you need to talk about. The second parameter that we need to talk about is till what extent is it present only on the ankle or is it extended along on the tibia also? And if at all till ischium. So, what aspect of general physical examination are you talking about when you are talking about pedal edema? What are you assessing?
Are you going to look for bilateral or unilateral? You looked on one limb, there is an edema, but opposite limb is not having edema. So what is the possibility? The examination, even for a hernia case, we can change out pedal edema. So every point is a lot of things.
So, you mentioned about well nourished, moderately nourished. So, what are the parameters that you assess in nutrition?
the external appearance.
That is not, these things don't work.
This is
You know, these things don't work. It's a quantitative assessment that's happening for you. So presentation has to be from that point of view.
You know, what is the reason why you are not able to do? You are not giving importance to that. You think it is okay, when you have a hernia case is given for an examination, you go even in the evening, you see only the hernia. You don't spend time for general examination. It is most important that you spend time for every patient. All the examination should be done. Even for a hernia patient, do all the examination of the abdomen. Because some of the patients will be cooperating. That you are not given, I know for sure this case you are not looked into his any of general examination you have done. It is only a theoretical.
So these are the things you should. All of you must spend at least a day reading general physical examination and pay attention to each aspect of it. If you're asked about nutrition, you should be able to talk about all those parameters being about carbohydrates, fats, proteins, and micronutrients, right? So you would say BMI, mid-arm circumference, bone thickness, and then you talk about pallor, vital spots, and all that. All this should come reflexively in a single sentence so that the examiner moves to the next question.
So ASCII, if it is really done in proper way of doing ASCII, then everything has a mark. There will be one case, definitely we will keep general examination. So whatever you are going to do, even right from the standing on which side and how you are going to ask the, greeting the patient, getting the consent, doing that, take marks for that. So that you should practice. Okay.
See, the purpose is handled here in the hernia is to sometimes pay attention to detail. Respiratory rate also in a male and a lady, how you will assess the two will be different, no? Whether it is abdominal, thoracic chest wall or the abdomen. All you need to put your hand on the abdomen or the chest wall and take a look at your body. You can't doing two things together. We move the
examination.
After local examination, after getting consent from patient with adequate privacy and right.
This is a right word. Examination of the left inguinal region, not the local examination. Put this as a first examination of the what region you are going to examine.
Regional examination of left inguinal area.
You have put only inguinal. Always we look for us inguinal scrotum. Okay.
Regional examination of left inguinal region. After getting consent from patient with adequate privacy and writing, the patient was exposed from umbilicus to mid-thigh level. Inspection a pyriform shaped swelling of size 905 cm seen in the left inguinal region, extending from a point 5 cm medial to the anterior superior spine down to the scrotum. The surface is smooth, skin over the swelling is normal, no visible peristalsis, calf impulse is present.
You have to be meticulous, these things will not be ignored in an exam.
What are the problems scrotum means? Up to what's the inguinal scrotum?
Where is bottom of the scrotum? It is close to the body. No, I am asking for that. They say 5 centimeters.
You can still give this all these parameters, no 5 centimeter from here, 10 centimeter from here. You could just comfortably say that you noticed a bulge.
I think that is very important that all the UGs, please don't come at the examination swelling 3 centimeter from here, 3 centimeter from here, 4 centimeter. All that is not needed. If you see thyroid region, we all know where is it. We know where is inguinal region start. This time don't spend, but actual time for the swelling and where the region exactly, you must say. And how do you identify anterior superior leg spine? Okay, go ahead.
You don't mention in which position you examine, and here we don't want to stop you to tell you that just taking consent from the patient is not enough. Even if it is a male patient or a female patient, you must have at least informed, or there must be at least one more person around besides you and the patient. You must say that you examine the patient in the presence of the responsible adult. Yeah.
Patient.
You didn't tell us now. In which position have you examined the patient? Go back to your previous slide, it's important. You have written, you presented a case of hernia. Is there no visible peristalsis and coffin present? Should I say there is no coffin or no visible peristalsis is separated coffin is present? You must mean what you say and say what you mean. There should be one and only one interpretation. Then we should gain from what you What is your interpretation of this? Both of these are not present or one of these is present? Coffin is present, visible peristalsis, right in the next line. Right separating the coffin is present is an important finding. Now what is the coffin? Is it an expansite coffin or a non-expansite coffin?
Why do you look for visible peristalsis? Which visible peristalsis?
Is it better now?
Have you ever seen a peristalsis? Because you said the swelling is reducible swelling. No? So you have seen a peristalsis there. You wanted to look for a peristalsis. No, don't say yes for everything. I know you are written as no peristalsis. How did you look for peristalsis? How will you look for peristalsis? So you are not done. So examination, every word you are writing, you should do. Do the examination. You know how to do the VGP, VIP? Okay. Okay, go ahead. No, where is the hernia? Is it a patient you are presenting or the Vignet or the online? Okay. You have now what technology has improved? You would have demonstrated the cough impulse. Now examination, when you are presenting like this, you should take a video, short video of the cough impulse. Then it will be beneficial for all. Now looking at this, we are not able to make it out. Okay, go ahead. Go here.
Palpation not warm and not tender. Inspection findings confirmed by palpation. Consistency soft and elastic. Expansive cough impulse is present.
So this is deep ring occlusion test. Your entire inguinal canal you are obstructing. Oh, your entire thumb is there, obstructing the whole. Whether it is a medial or lateral, no swelling will come.
Deep ring occlusion showing doesn't appear. Siemens treatment test. Impulse control the index finger deep into the ring. Finger imagination test is not done. The cord structures and tests are palpable.
Where did you feel the cord structure? So getting about the swelling is positive. So where did you check for the cough impulse? Or you felt the cord structure? What is silk sign? Structures, whether it is hypertrophy, whether it is a cord is hypertrophy or cremastinal muscle is hypertrophy.
And when you must try to evaluate it on both the sides. What are the other interpretations that you can get in the case of any other abnormality that the patient may have? Cord structures must be examined and evaluated in all patients. So is there any other pathology that may be there in the cord in which a positive cough impulse may be present but may not be expansive?
It's confined to the cord, some sort. Swelling is confined to the cord. You know any swelling?
We want you to tell us about some other swellings other than hernia, which can have a positive cough impulse. See, no matter rocket science happening here, what we want you to have you heard of varicose? Varicose may have a cough impulse. Is there any other? Okay. Yeah. So next time.
Go ahead, Vikas.
So resident note of this swelling is the swelling calculated and diagram. Sir suggested during his presentation. Was the swelling calculated and diagram position? No. So and in the hernia, the patient will stand with your aorta so the hernia will keep going in. So it doesn't really have much value.
You could hear the normal bowel sound also. What is the normal bowel sound? What do you mean by normal bowel sound? Gurgling sound is a normal bowel sound. So you are always in a tense mood. What is the heart rate? How much is normal heart rate? So similarly, bowel has a rate. How do you hear the bowel sound? It is the sweetest music to the surgeon, bowel sound. The strength is not only for hearing the heart sound. You must always put your strength, identify the bowel sound, hear it. So then only you will be able to make it out. And nobody will go to the hernia like this small, put a strength and find out your bowel sound is not there or not. Okay.
Examination of right inguinal region. The hernial orifice appears to be normal. Large structures and vessels appears to be normal.
There is only one hernial orifice. How many hernial orifices there? No, right inguinal. You said hernial orifice appears to be normal. Which orifice you are talking? Deep inguinal ring, superficial inguinal ring, femoral ring? All you have palpated. But then it is a plural.
Examination of penis. The penis is shifted to the right side.
Penis is shifted. No. Can a penis be shifted at any time? Penis is the most strongest pillar with anchored with the 3 pillars. The tip of the penis can sway anywhere. That's a normal phenomenon. Because you are not going to look for the penis cannot go from the midline to the left thigh or right thigh. There is no case. You can see a buried penis in whether it's lymphedema or something like that. Penile urethra, you palpated the penile urethra and normal.
Examination of abdomen. Thorax muscle appears to be normal. No underlying bulging or straining. The abdomen is soft, no free fluid and no organ mechanism.
What about the other hernial orifices? We told us only about the groin. So talked about malignant emphysema, when you have one hernia, they can be hernia at other positions also. What are the other hernial orifices that you look for?
No, that is what internal hernia. Myopectoral orifice, you are the other than that, you can get a lumbar, you can get an umbilical.
You speak of mention that all other hernial orifices are apparently normal. How did you test for malaria in this sponge?
Patient asked the patient to lie on the recumbent position and then let this ask the
Which muscle gets contracted and leg easy? Not at all. On leg easy, the major muscle in the abdomen is leg easy, always the legs contracted. And the only muscles also contracted partially. You will be able to recover malaria as very easy also. What would be a better test to do? Look for malaria sponge. You can ask the patient to do this at last one. All the oblique muscles will also contract along the time.
Do you know there is no free fluid? Is there a free fluid in the abdomen or not? No. No, you are written. I have never seen a patient with no fluid inside the abdomen. That means entire everything is dry. What is the minimum fluid required to measure? Your podal sign or your shifting dullness to that. How much is it?
See, have confidence in yourself. No? You know the answers to your answer. You know that please get here to interact with you. So you don't have to be scared of anybody. You know? So fluid, you written of free fluid. So fluid will be present in small amount. When fluid is present in small amounts, how do you do how much? When moderate is there, what test do you do? When gross distension is there, what do you do?
Fluid thrill. You are not the abdomen at all.
So as an examiner, when you are assessing, you all aspects will be assessed. One is that whether you are aware of the disease process only. Second is that do you know, are you updated in your clinical examination skills and general physical examination? Once you start answering that, you want to know are your basic sciences updated or not. So a few questions on anatomy will also come, anatomy, physiology, and all that. And then management. So you have to do an all-around kind of exercise on this. What is your diagnosis?
Time up. Put the belt strong. Otherwise, it will not. No. You have to go. Stop. You have done the parental examination. Which sphincter tone you assessed? There is two sphincter tones. What is squeezing pressure and resting tone? Which one you assessed? Resting tone. Okay. It's produced by which muscle is responsible for resting tone? And you are very particular, prostate medial sulcus not obliterated. Now, after the COVID that has happened, they only present which is in the book and they don't examine the case. You could even go to the medial sulcus not obliterated.
Examine the medial sulcus. What is the focus? Writing medial sulcus is not obliterated. When does it get obstructed? Not at all. You know, your biology is totally in a different direction. What is the first clinical sign of BPH?
No, sign.
Sign. On digital rectal examination, what is the first thing that you feel in a patient of BPH?
It is not the computer digital. We are asking the hand, finger.
Can you tell us the digital rectal examination findings of assessing BPH?
When you do a digital examination, what are the findings to say it is a BHP, prostate is enlarged? It must be said it's a benign prostate, it's not a malignant prostate.
Is not the prostate parallel? It is parallel because it's going towards unacceptable answers, right? Anatomy again. Normal prostate is parallel. So when you say it is enlarged, that's okay. It's okay. We don't want everybody to scream at them. for a reason. Isn't it? When you're talking to your colleague also, you're speaking for a reason. Every sentence, every word has a meaning. Similarly, when you're presenting a case, this is what you're doing. You're talking to the examiner and you're interacting with you. No stories need to be quoted. Nothing which doesn't have a meaning has to be spoken, because everything will be treated as a negative front from us if you give us a negative feedback. Because you're trying to refool us then, right? Which will not be accepted. So speak whatever you know, speak only those signs that you will be able to demonstrate to us. Whatever we can introduce there, only that has to be spoken and written.
So examiner, we never expect you to say everything, to know everything. But we are going to ask only from what you say that I know. You are put at medial sulcus is not obliterated. Then we have a right to ask a question, when it will be obliterated and what is the sign.
You written no prostatectomy, you don't know if normal prostate is pelvic or not. It is no meaning. Right? What is the association of prostatectomy to obstructive urinary symptoms?
Is it correlate? The large prostate will obstruct more. We have only 5 more minutes. Indirect inguinoscrotal. I'll find out. You have better intro sit with the bowel sound here. You come back with the diagnosis, then all the findings you cook up.
So this short clinical examination finding that will tell you that you are dealing with epilepsy. Bowel sound speaking in this room, sound will be heard outside this room. Bowel sound will be reduced to the abdomen when you are sitting in front. Tell me one short sign to say that it is an epilepsy. Be loud and clear and speaking loudly. That is, if it is a partially reducible thing or irreducible.
You are there.
Points in history, points in examination, patient will tell you the why. Short sign, consistency may be subjective. In history, patient will tell you that when I reduce the swelling, I can get a burden. When you're examining the patient, you're reducing the swelling, feel a burden in your hand, you know you're reducing the volume. Momentum can't be reducing the burden.
Okay. Why do you want to do USD abdomen? Rhodositis. You are clinically you said no free fluid. Now you want to ultrasound to rule out. What is the purpose of doing ultrasound in a case of inguinal hernia? Rule out BPH. What do you mean by that? So what? What is the sign in ultrasound saying that it is? You will have a sure sign that is. You hear the word residual urine, post-vital urine. How much? It is only all or none phenomenon. Even if 1 ml is there, it is residual urine. Is it the only purpose of doing ultrasound? Defect in the for what? You know what is EHS classification stage? Say, do you have anything to say on the size in the EHS? Okay. 2 finger blood is normal. We are talking about a human finger, not rat finger. Okay. Alexa has been well considered. Treatment on ஆ
Good, keep